Inflammatory bowel disease. Pediatric inflammatory bowel disease IBD is around how much? 25% of the IBD it occurs in below 20 years of age. Actually, IBD has bimodal distribution. In the childhood, 10 to 20 years age group. In the adult, 50 to 80 years age group. There are very early onset IBD, BOIBD, in a small subset of cases. It is of three types. Crohn's is more common in the children, ulcerative colitis thereafter, and 10% of cases you are really not certain in determined type. So their presentation is blood, mucus, pus, and your tenesmus, urgency. It simulates almost an invasive diarrhea, dysentery, the infectious colitis, bacterial, parasitic, and HIV and fungal. Genetics and then syndromic associations may be there, and the diarrhea can be a presentation simulating acute viral diarrhea. Remission and relapse are characteristics of the disease, and even without treatment. Disease has fever, fatigue, and growth failure, anemia, usually normocytic, normochromic, the chronic anemia pattern, and can be microcytic hyperchronic anemia. So there can be extraintestinal infections like the hepatitis, cholangitis, ankylosing spondylitis, and other musculoskeletal disorders, amenorrhea. You have arthritis, your rhabdomyolysis, your skin, aphthous glossitis, and your even the erythema nodosum. They are all possible. Various types of ocular inflammation is also possible, and you have the cardiac involvement. You may have the hematological, and then your hemolytic thrombocytic picture. Even in the kidney, there can be membranous nephropathy and nephrotic syndrome presentation, stone, and your hypokalemic nephropathy, pancreatitis, and neurological involvement may be there. In benign intracranial hypertension, and your even neuropathy is there, can be there. So other comorbidities like malignancy, the woolly hair trichohexis and dysmorphism and macrophage activation syndrome, all are possible. So diagnosis is by endoscopic biopsy and histology, and fecal calprotectin can be a screening test. Other inflammatory markers, they are adjunct to understand diagnosis, and the extent of disease, extraintestinal disease, can be identified by investigating the disease lesions on those sites. Treatment is no definite cure is till date known to people, but the inflammation can be reduced by prednisolone, mostly oral, can be given IV also, and the your first line drug may be sulfasalazine. If it reduces inflammation, 30 to 100 milligram daily. Better tolerated one is the mesalgine and the valsalagine. So go on giving it until the disease is induced, active disease is controlled, and your then you have maintenance drugs like your other disease modifying agents, azathioprine, 6 mercaptan maybe a little bit low dose prednisolone, and along with sulfasalazine. So moderate to severe disease may need infliximab, and your other monoclonal antibodies like adalimumab, and then methotrexate is not also bad over here. Finally, in very severe disease, you need to go for the colectomy, maybe hemicolectomy, maybe partial or whatever. The outcome is not that bad always. At times it is guarded.